Welcome to Sonata Insights Live. I'm Tara Murphy, Senior Director of Global Marketing and Advocacy. Sonata Insights Live is a program that we've launched to spark conversation about fibroids, the symptoms of fibroids, and talk about what your treatment options are as a patient. During these episodes, you're able to hear from guest physicians, patients, and advocates as they share stories to educate our audience. Today, I'm very excited to be joined by Dr. Dipak Delvadia. He is a board-certified board-certified in obstetrics and gynecology, and currently he is practicing as a general OBGYN at Virtua Voorhees Hospital in New Jersey. He was the principal investigator for a clinical trial that we did here for Sonata, which was called the Pivotal Trial in the United States in 2016 through 2017. Dr. Delvadia has performed over 50 Sonata procedures and is also a clinical assistant professor at Drexel University College of Medicine, Rowan University School of Osteopathic Medicine, and Jefferson Health. His passion for teaching students, residents, and faculty has led him to holding various committee positions with local and international universities. Dr. Delvadia is also an active member of the Oral Board Examiner for the AOBOG, past president of the Philadelphia Obstetrical Society, and ACOG Global Fellow. You are a busy man, Dr. Delvadia.
Yeah, thanks. I think I've been also busier with some of these Sonata procedures as our numbers have escalated even beyond 50 to close to 100 now.
Oh,
And
fantastic.
glad to have a discussion tonight. And thanks for that introduction, Tara.
Yes, I'm happy to have you here. So, really, what our goal is today is to have a casual conversation where we could help patients to understand really what are fibroids and how common they are. You know, we hear from women a lot that they thought what they had was normal. They thought that their symptoms were normal. Meanwhile, such a large percentage of women have fibroids. So I really want to start with the very, very basics with you, and then we could start to talk a little bit more about what the treatment options are and what Sonata is.
Yes.
So,
And yep.
yeah,
So fibro, and when you mentioned the common,
yeah.
that's a very first thing that I get asked by the patients is, once they have a fibroid diagnosed and know about fibroid, they start to realize how many other friends and family members and other people have also fibroid. And so that becomes more in their world of thinking. And all of a sudden they start to ask me, it's like, what's going on? Is there like a big increase in present day? But it's actually been around and has always been a trouble for a lot of our patients. The symptoms of fibroids, which is common as 1 in 5 women to even more. In some areas, even prevalence is higher, but it's one of the definitely more common etiologies. And also, at the same time, not all patients that have fibroids will have same symptoms. So that's
Mm,
the part that I think is most important to separate and delineate. Just because you see a fibroid on a study or an exam and you notice a fibroid doesn't mean that it's always going to have this similar pattern of problems. And some patients may not have any problems at all. And so we're focusing more of our treatment on symptomatic fibroids, specifically in our initial pivotal trial. As you mentioned, we
mm,
chose patients who've had heavy menstrual bleeding as one of their most important and prominent symptom. And we took those patients, treated them with Sonata, and with the proper all the guidelines and exclusions and inclusions for the study. And from that, we noticed significantly over 90% of our patients that had treatment success of decreasing their bleeding in the first year. And then even beyond that, we've had 3 to 5 year data now, which are also very good and staying strong in terms of helping with their symptoms. So I think making the diagnosis and then also making the proper setup in getting the treatment. Sonata is one of the treatments, as you also alluded that what are other options. Well, in that, the first thing we got to do is the diagnosis. Once we
mhm,
make the diagnosis, then I think we jump into what options there are, starting with the less invasive medical treatments, even if possible. And Sonata is right at the early stages of the one of the options of treatment because it is very minimally invasive.
And can you talk a little bit about, for women that don't actually understand what a fibroid is, in
Right.
simple terms, how do you explain what a fibroid is to a woman when they come in to
Yes.
see you?
Yes. And as simple as it is, it's a proliferation or thickening or say a cellular duplication and collection of material where um, part of the smooth muscle starts to develop and become abnormal in growth, almost like a cancer, meaning that it grows and proliferates and mimics almost being like a cancerous type cell. But anywhere along the muscle of the uterus, some of the cells can change and become thickened and proliferating and increase in size. So then you can get a something that we see on the ultrasound as we call fibroid. It's a smooth muscle, dense tissue that becomes almost like a ball, usually round, but not always, and sometimes multiple rounds in multiple areas of the uterus. But these fibroids are smooth muscles of the uterus that are thickened and proliferated, that are abnormal. And depending on where that occurs in the uterus, how it causes the symptoms. They can be in the size from less than a centimeter or, say, blueberry size, or even a little bit smaller, to all the way to grapefruit size and even melon size, like cantaloupe size.
Oh. And so you had mentioned that women come in with different symptoms all of the time. Can you talk a little bit about what types of symptoms you see from women suffering from fibroids?
Yes, most of the time, if the fibroids location is very important. In other words, that's like real estate. Location, location, location is a big important piece of where the fibroid is positioned in the uterus. If the fibroid is in the cavity where the baby grows, we call it intracavitary, then those type of patients will have persistent bleeding, almost kind of like on a 2 to 3 times a month, or maybe even daily for days. And many of those patients that we see with the fibroid in the cavity, they come in and they're so anemic all of a sudden within a couple of months or less even, that they need evaluation of that cavity and removal of that fibroid, sometimes even by cutting it out through what we call a hysteroscope. So the intracavitary fibroid, there are locations based on, we call it type 0 all the way through type 8. But type 0 is in the cavity, type 1 is in part of the cavity, but part in the muscle. And then type 2, 3, 4, 5, even up to 6 are all within the muscle, but then they go away from the uterine cavity. So the location can make a difference in this patient's symptoms. So ones that are in the muscle, the tumors that grow in the muscle of the uterus, they're the ones that cause heavy bleeding. Besides heavy bleeding, you can get a lot of pressure, like um, uh, constant pelvic pressure that occurs because the actual fibroid is occupying extra space in the pelvic area. So it pushes on the bladder, pushes on the bowel. So you get a lot of the symptoms of bloating, pelvic pressure, pressure on the bladder, pain with relationship. Anything that causes extra pressure in the pelvic area can cause more of those symptoms. So we call space occupying type of symptoms. And then other type of symptoms are the bleeding type of symptoms, like heavier cycles or change in the cycles to become monthly but heavier, or constant, like 2 3 times a month, and to a point where it's about 2 to 3 times or more the normal amount of blood loss.
So we hear a lot of times from women when we're doing these patient education events together about, the stories that they have where they have to change their clothes multiple times a day or take a change of clothes to work with you,
Right.
um, have to get up in the middle of the night to change sheets and things like that. Can you talk a little bit about, every woman is different, but, what
Yes.
is normal as far as bleeding, as far as changing, a pad or changing clothes and things like that when you
Sure.
have a cycle?
Well, yes, every woman is different, but I know from taking care of women all my career that women are strong, and many of the women are not going to come in with the signs and symptoms at the beginning. And because most of the time patients will say, oh, it's going to get better, or it's just a change as I'm getting older. My cycles are normally are getting older because that's what my family members told me, and that's what my friends tell me. So it's kind of like something that patients don't take upon until it becomes very symptomatic. And most of the patients that we see when their cycles get heavy, it's after 2, 3 years later that we see them. We rarely see them more on an immediate time. In fact, most patients that are fibroid, from our data, shows that they don't really present at least 2 or more years later after they've been diagnosed or they know about it. And so that's what wears down their system, where they become anemic, or they become more and more sensitive, or they become so how should I, like, I had several patients tell me that they, like you said, they go to work and they'll have soiling of the clothes, and people see that, or they're kind of afraid that they'll see that, and there's become a more traumatic experience for them, and in
Mhm.
such a way that it just becomes a more psychological effect on how they do things. In other words, they won't go to public spaces, they'll minimize their activities, and which then causes more the burden on their health and causes even more difficulties if they're less active, more weight, a lot weight gain, and other issues, psychological issues as well. So there are definitely other things that patients will start to manifest besides the initial problem of bleeding or pressure that may have been happening. It becomes kind of more evident on their surroundings. And so our goal is to identify that those type of patients and make them understand that this is not normal, that this
Mhm.
needs to be taken care of, and there are some proper steps to take care of, and how to take care of it, the problem, and rather than just jumping always to one thing, such as major surgeries like hysterectomies or myomectomies. So thankfully, we have a lot more things in our armamentarium that we can actually use, a variety of other minimally invasive treatments and techniques.
So, how do you diagnose fibroids? How is a woman does a woman find out that she has fibroids once she comes into you with her symptoms?
Right. So majority of the time initially is the history or the symptoms of how the cycles and
Mhm.
bleeding and the pattern of bleeding, especially if it's changed and new for them. And then exam, we can see just by feeling the uterus. Uterus is normally like size of the fist, or like it's about, we call it like 8 centimeters. Most patients don't realize that it's that small, yet can carry a big baby, etc. But
Mhm.
on a normal uterus that's non-pregnant, it's really small. And once we know on the exam that the uterus is feeling bigger, maybe double normal size, then we would typically get a ultrasound. Ultrasound would help us kind of determine if there is fibroid or there's some other type of abnormalities within the uterus that's making that uterus cause the symptoms such as bleeding or pain or pressure during the time of cycle, or without any cycles. So ultrasound is a big help, and then once we do that, then typically other studies can be done, but not necessarily needed. MRI is helpful if we kind of get confused as to what the ultrasound is telling us. If the fibroid is not adequately seen or positioned, or too many fibroids are there, then sometimes MRI can be helpful. But typically, ultrasound is our biggest tool, and exam definitely kind of combine those or two factors, and gives us the best scenario.
And there's a wide range of treatment options. So it's always important for a woman to, find a physician like you who's talking to them about all of the treatment options that are out there. Can you talk a little bit about, how the symptoms range from, or I'm sorry, how the procedures and treatments will range from least to most invasive?
Right. There are definitely a lot more available options than in the past, especially more minimally invasive type options that are there. But the first thing is that we want to make sure that patients realize that they should become comfortable to talk about this and bring the symptoms to their physicians. And if you have something, look for some of the minimally invasive options in case. they're not guided that way. For example, the first thing that I would want to do is I want to make sure, based on the patient's age, that we're not looking at possibility of some cancerous changes in the lining of the uterus or other things that can cause bleeding. One of the most common cause of, oh, I'm sorry, going back, the most women that have early endometrial cancer or cancer of the lining of the uterus will have bleeding as their number one symptom.
Mm.
So we want to make sure that based on age, especially after near 40 or above, that if they have a heavy bleeding, that we want to do a sampling evaluation of the simple like cavity, look inside, get an ultrasound, get all the tools to make sure that you're not running into something more invasive type of problem. When you have a benign problem, most of the fibroids are benign. There are some fibroids that can be cancerous, and we can talk about that after or later. But basically, we want to make sure that patient is not too anemic, has proper medical care, and taking care of themselves well, eating well. And once we make a diagnosis that the fibroid may be causing this, the first treatment, and maybe simple, is to try hormonal agents
Mhm.
if possible.
Mhm.
Many of our patients, like I said, come in already 2, 3 years of knowing, and they've already tried a bunch of medical treatments, such as hormonal treatments. And if they are having symptoms with that and they can't use that, then I do put them on something called tranexamic acid. Again, if they don't have any side effects or problems in their past history that you cannot use tranexamic acid. Tranexamic acid, or TXA for short, is very helpful, and it's used to stop and decrease bleeding when the cycles are happening. And I use this in preparation for a patient to get to the surgery to help them improve their anemia.
Mm.
So I'll get the evaluation, get them started on potentially some medical treatments, and then as we go along the path, that if medical treatments are not working, then some of the simple tools would be starting with a Sonata treatment, or possibly hysteroscopy to look if the cavity has fibroid inside that needs to be removed or resected, especially if there's certain type of fibroid, like I mentioned earlier, that are completely in the cavity of the uterus. If they're in the muscle, then and we think that they're probably the cause of the bleeding or the symptoms of such as pressure or pain, then Sonata fibroid ablation treatment would be my next line. And like I said early on, that Sonata is a very low invasive, minimally invasive procedure, that it is a application to a lot of the patient's problems, and should be used as a first step before many of the other invasive treatments that would be used based on failure of some of the minimally invasive techniques. Then, of course, for Sonata, then we'll do prior review of who the patients are and the candidates and qualifications for that. Most patients that have fibroids that are less than 7, 8, even 9, 10 is the upper limit, but mostly 7, 8 centimeter size fibroids that are in the muscle of the uterus can be treated with Sonata ablation. And so we'll go through that and show patients some of the diagrams, the pictures, things to kind of make them understand that these are the fibroids that they have, and these are the ones that we can treat with Sonata. So my definitely go to initial and right away technique for treatments for symptomatic intramural fibroids is to go with Sonata treatment.
And can you talk a little bit about how Sonata works, what a patient would expect when they would have the Sonata procedure?
Yes. So most of the uh, as I mentioned, the Sonata is a very minimally invasive. Invasiveness is because there's no incision, no cutting. Patients recover within less than a week, or at the most about a week of recovery. Outpatient treatment, so that you go home the same day, same morning. Um, so procedure involves using a probe that is, I say, about the size of my small finger or in thickness. So we put the probe inside the uterus. That probe at the tip has an ultrasound. That ultrasound will detect fibroids right through the uterus. So in other words, where the opening of the uterus is, where the baby comes from, we put the probe right into that opening through the vaginal canal, so we don't have to make any incisions. We go in and we look at the uterus size, shape, and map out all the fibroids. That's the first step. When we do the fibroid mapping, we realize that's where the location of the fibroid is, what size they are. Often, and almost every time that I do this, we find that we always notice more fibroids than we were told from the ultrasounds that are done, routine ultrasounds that are done in the radiology department. That's because our probe is actually inside the uterus rather than the other ultrasounds done through the
Mhm.
um, abdominal wall or outside the abdomen that has to go through lots of layers and sometimes not as easy to do those type of ultrasound studies. So when we get the ultrasound to help us detect the fibroid, we find the fibroid and we put a needle probe in there. This probe needle goes in. It's about a size of like an IV, like a needle that you use to put the IVs in. So that needle goes in and it will then engage the fibroid. And based on our computer technology that's developed by Sonata, we would ablate that fibroid to the size of the fibroid that is measured. In other words, if the fibroid is 1 centimeter size, we make our device sense that it's a 1 centimeter ablation. So we make the zone appropriate to that fibroid size so that we're not damaging anything outside of that fibroid. So we would find multiple fibroids during the procedure and we would ablate sometimes 5, sometimes 6, sometimes 10 fibroids. And each of those ablations are done individually based on our findings with the ultrasound probe. So in simple terms, Sonata is a transcervical, so it goes right through the cervix, using ultrasound probe, finds the fibroid. Once we find the fibroid, we put a needle in it. That needle will heat the fibroid to high temperatures like 100 degrees Celsius. And once that is done and treated, we remove the needle, remove the instrument, and then over time, that fibroid that has been ablated will shrink and become avascular. Avascular means that the blood supply to the fibroid is cut off, and so the fibroid will not grow, and fibroid will actually shrink over time, and that fibroid will then cause less of a burden and problem to the uterine muscle and the surrounding. And we do this in a selective fashion, so we're not damaging any part of the normal uterus muscles or the surrounding structures, such as intestine, bladder, and other organs that are near there are not damaged or cause any harm to them.
And how long does the procedure normally take?
Procedure itself is if I have 1 or 2
Mhm.
fibroids, it's about 15, 20 minutes. If I have, like, say, my average patient is about 4 or 5 fibroids, it'll be about an hour.
Mhm.
And I have had some patients where I've had more than even 10 fibroids ablated and have taken up to 2 hours. So the average is within the hour.
Mhm.
We can pretty much treat with, simple fibroids that are say 4 to 5 in the cavity.
And patients go home same day?
Yep. So the anesthesia also, it's a simple anesthesia. We call it twilight, something that people would get for other procedures like
Mhm.
colonoscopy, endoscopies. It's IV medication to help patients relax. When we are doing the procedure, patients are breathing on their own. We don't have to intubate them or put a tube in their throat. We don't have to put anything we call general anesthesia. With IV sedation, patients are comfortable. They don't remember anything. They don't feel any pain as we're doing it. They're not moving when we're doing the procedure. They're not moving around or causing any signs or showing any signs of pain. Once the procedure is done, they're in the recovery for about half hour, and because it's not a general anesthesia, they wake up pretty quick without any significant irritation to their airway. And after about 1 hour from the procedure being done, most people are walking out to home. Recovering at home is somewhere between, like I said, up to 1 week, but I've had patients go to work the next day. I've
Mhm.
had patients travel next day. So it is amazingly very painless type procedure. At most, uterine cramping that can be controlled by ibuprofen. So recovery as well as the immediate and longer recoveries are both without any significant burden.
And I think that's really important because, we as women tend to always put ourselves last because we have so much to do with our family and work and everything else and taking care of everyone else. So I think a lot of the time that we see patients wait, which on average, can be at about 3.5 years before they even seek treatment, is because we don't want to take the time for ourselves. So we just kind of keep putting it off and putting it off. But having such a quick recovery time, which varies, a few days per
Right,
patient, but having that in the back of your mind makes it more realistic to be able to actually,
right. It
rather than
is.
just
It
trying.
is. When the recovery is faster, I mean, patients really prefer that because most patients are very busy. Even if many patients, with family or without family, like their work and
Mhm.
lifestyle, I think almost everyone, has some things that they're doing. And we're also treating patients that are in that age group of like somewhere usually in the 30 through 60 years of age, and which are the more active type patients that are always on the go. So any, minimal amount of time off is always helpful.
And what do you see as far as results from your patients? What do you hear from patients after they have Sonata?
So it's most patients immediately right after in the recovery room, they say that they feel a lot less pressure in their pelvic area, especially if they've had multiple fibroids. And majority of them within their first cycle, they are having less bleeding, almost 50% less bleeding on the first cycle. And then that has been good and has been helpful, as I mentioned earlier, that the 90% of our patients with heavy bleeding had still symptom control year out. And even beyond that, 3 to 5 years, we have data up to almost 80% of the patients that have had no other needed treatment or that their bleeding and their symptoms were controlled from the initial treatment with Sonata.
It's great. I'm glad to hear that they're doing well. How else can we help women? We want to make sure that they understand that there are a variety of treatment options and how important it is to be talking to a physician that is understanding what their journey is as a patient. What advice could you give to a woman when she's doing her research and looking at, options from medical management through hysterectomy, because we want to make sure that they do understand all of those treatment options. What advice do you give a woman as she's meeting with physicians and maybe not hearing her, having her voice heard, or doesn't feel that she's having her voice heard? What can you say to them?
So, the first important thing is that to don't undermine your symptoms and the problems and things you're going through. I know it's been difficult because in our field, there's just not been many choices out in terms of minimally invasive. Sonata has opened up a few of the different direction for patients to get treated. And so stepping up and going to get evaluation, making sure that at least you don't have something even more on this extreme end of cancerous changes. Once we know that it's a benign type of tumors that may be causing the symptoms, then looking for treatment options and understanding them. So, um, and I think there's one picture, I think maybe it's on the website, that really shows that different options that are out there, such as in a minimally invasive category, such as uterine artery embolization, Acessa, and Sonata are the ones that are commonly thought of. In that comparison, also want to say that uterine artery embolization, it is a procedure that I've had many of my patients have gotten in the past and less now because of the availability of Sonata. And it's a technique that is done in the radiology department where the catheter is passed in through the groin and into a big blood vessel that supplies the uterus. And from there, they can stop some of the blood flow to the fibroid. It is not as precise and it does cause a little bit extra pain, but it is an option that is available and can be researched. But comparison wise, Sonata is less invasive and can most of the time get you the same or better results. The Sessa is the other one of the treatment options that is probe that is similar to the probe that is used for Sonata and is used through the belly button. So you have to have a general anesthesia and it's an incision through the belly. So it requires a little bit more invasiveness. And so comparison again to that, if the Sonata can be used and can be applicable, then it would be a better treatment. But those three are the initial treatments that are should be approached before any major surgeries like myomectomies or hysterectomy. Some patients have a uterus that are way out of the zone for getting treated with minimally invasive treatments. Then the other treatments should be looked at, such as partial hysterectomies or myomectomies. They do have their place in the whole armamentarium of treatment as well. And but important piece is that not to panic and get scared, be open-minded, talk to doctors and physicians and team members that are aware of all the options, and they can at least guide you in a better way and give you a little bit of a better and broader perspective of how things can be treated. It is individualized, all the treatments, as fibroids are individually different for each person and where they're located, where what type of symptoms they cause. But stepping up and finding the physicians, providers, people that are aware of a variety of minimally invasive treatments, and starting there, making a proper diagnosis is the best way to start.
Absolutely. We have a question that's come in. Is there data for women with fibroids who want to become pregnant?
Yes, it's a question that is comes up quite often, and uh, majority of the patients that I see have past the fertility, but I do see patients that are younger in the 30s that are still trying to get pregnant, but their cycles are really too heavy. They've never had a pregnancy and they're trying to get to the point of pregnancy, or they've had actually myomectomies in the past and they were not able to get pregnant and they're still suffering with heavy bleeding. And I see them as well. The message I give them is that there is a data there, but we don't have a what we call a randomized study where we can compare a group of patients that did get Sonata and the group that didn't and follow them for pregnancy outcomes. However, patients with Sonata over in the US as well as in Europe and other countries have gotten pregnant after Sonata, and those patients have done well. The data is getting bigger and bigger. We started with, I think, somewhere near 50 pregnancies, and I think we've gone past that number. So, a number of women that are able to achieve pregnancy which they thought was not possible, or maybe they got pregnant as a more accidental after Sonata treatment was done and their cycles were better and their fibroids were smaller, that they became pregnant without knowing. Those women that are followed have done well. So the effect of the pregnancy and the data retrospectively is good. And the reason it's actually makes sense that it's good is because I was going earlier to tell you that when we do this ablation, it's a very, very specific area that we're ablating of and really ablating only the fibroid. Even some of the myomectomies or removing the fibroid with a surgical treatment can't get that type of clean without damaging the surrounding tissue approach to treating a fibroid. Um, we are not able to fully shrink 100% of the fibroid. So the fibroids are still there, but they're half the size or even less. And so we are looking at all that data to see if any of those things are going to affect the patients in the future pregnancy. But so far, the patients that have gone pregnant have not had any issues that are complications related to procedure from Sonata. So my message would be that we don't have a data, but we actually say that let's treat your fibroid, let's make your symptoms better, and then once you get through that phase, you can decide on possibility of if what your future may hold. If you are thinking about getting pregnant, based on what the locations of your fibroid, how the fibroids can be treated, Sonata can be used, but with caution because we don't have a high number of people or women with data of pregnancy after Sonata.
Is this treatment available for women with adenomyosis?
I have now treated about a dozen patients, maybe somewhere near at least close to a dozen patients with adenomyoma. In fact, this last week I had a patient that came in that had a what the MRI and the ultrasound showed was a 6 centimeter adenomyoma or adenomyosis. So adenomyoma and adenomyosis are unique in that they are a little bit different than the fibroid in their characteristics of how they are physiologically as well as cellularly. So adenomyoma, if it is focal meaning one part of the uterus, or adenomyosis is only, say, a part of the uterus, I think there is a benefit of using Sonata for those patients. I have about a dozen or so patients that I've treated. I'm keeping monitoring of them, and I'm hoping to come put that data together and analyze it to see how their patient symptoms are. In the initial, what I have seen, patients have been symptoms free. One patient that told me that she had so much pain with each cycle that she couldn't even think about leaving anywhere. And after we did Sonata ablation of the adenomyosis areas, that she was actually able to function even within that first week that I saw after the procedure. So, seeing and hearing that, I'm hopeful that I think there is a place for Sonata in treating adenomyosis and adenomyoma, especially if it is focal rather than diffuse. If the entire uterus has diffusely endometriosis or adenomyosis, then those women may be difficult to treat with Sonata type treatment.
Thank you. I have two more questions that have come in for you. One is, how long will symptoms continue after the Sonata treatment?
So most of the depending. So if the symptoms are bleeding and heavy bleeding, majority of the symptoms will improve. Like I said, within 3 months, most people will see improvement. The location of the fibroid is a key. I've had of the 100 or so ablations and procedures and patients that we've treated, I've had about 4 or 5 patients that I need to take back for removing a part of the fibroid that had sloughed into the cavity. In other words, when we treated the fibroid that was in the muscle with Sonata, that Sonata softened the fibroid, decreased the blood flow to it, and then that fibroid worked its way into the cavity and then started to irritate the cavity. So that 6 centimeter fibroid becomes like a 2 to 3 centimeter um, a piece of fibroid that becomes part of the cavity that has to be removed because it will constantly irritate the cavity. So I've had that type of procedures needed on few patients, but most patients are symptoms free within 3 months. And now I've seen patients even 2, 3 years beyond the ones that I've treated from 2021, even that are doing well without any needing treatment.
Great. And can the fibroids that were shrunk with Sonata but are still there be treated a second time?
Yes, that's another good question. So far, since 6 years or so I've been doing this, I've not had repeat Sonata that I've done on anybody yet.
Uh,
And I say that yet because I don't know, but what the reason is that once we do Sonata fibroid ablation, the fibroid is pretty much devascularized. In other words, the blood supply, blood flowing into that tissue is stopped. So, and that tissue, even though it may not fully go away and it shrinks to even 30, 40% less than what it was, it's going to cause less symptoms. Now, that particular fibroid may not be causing trouble if there are other fibroids, maybe are newer, that are new in growth, or the fibroids that we couldn't fully treat before, they might start to cause trouble. And so we can determine that on the MRI. When we look at an MRI on the patient who's been treated with Sonata, the MRI will show that there is a decreased blood flow to the area of the fibroid that we treated already compared to the fibroid that was not treated. So if we find new fibroids, I believe that there is a definite place for repeating Sonata.
And one more. They just keep coming in for you, Dr. Delvadia. What kind of side effect discharge should I expect?
So most patients that do have treatment, I kind of warn them that there's going to be some discharge, like watery discharge, that is without smell, without itching, without irritation, or not symptomatic, other than just heavier flow. And the reason we think that it happens is that we're putting a lot of heat or temperature, increasing temperature in that fibroid. So it's like if you had a burn on your hand or something like that, or body, that burn weeps a little bit as it heals. So I believe that tissue is going through the changes and is releasing a lot of fluid, and that is a normal response from the body when something is ablated. So because it's close, some of the fibers that are close to the cavity, they will cause that swelling, edema, and lose a lot of the fluid type of discharge into the uterus, and then will come out through the cervix and vaginal canal. So most patients will have a heavier discharge for 1 to 3 weeks, sometimes longer, but majority of the time, it is gone within the first month after the procedure.
Okay. And if someone has developed additional fibroids, can they be treated?
Yes. And lungs of fibroids are reachable, and the types that we can go through the uterine cavity, they can be treated. And as I think we do more of these procedures, we'll see patients come back. The important key that I forgot to mention earlier is that getting the fibroids treated early, meaning like when the patient first discovers them when they're younger, 30s, and et cetera, is helpful, because if the fibroids are 2 to 3 centimeters before they become 5 to 7 to 8 centimeters, are much easier to treat, and those fibroids are not calcified, not hardened, and likely will have a better results of shrinking and not causing further change. Then it becomes harder to treat, or maybe sometimes we can only partially treat, which then may give us more chance of not getting the success.
Thank you. I think you've said a lot of very important things today. Know your body, take your symptoms seriously, find a physician that's going to listen to you, and
Yes.
make sure that you're an advocate for yourself. So thank you very much for all of this great information. I know you have a very, very busy night at the hospital tonight, so I appreciate you taking the time out of your schedule to be with us and help to educate women about fibroids and all of their treatment options, including Sonata.
Yes.
Thank
And
you.
that's the most important message, is to definitely listen to your body, get help. There's a lot of great physicians, teams, providers, nurse practitioners, even staff that are dedicated, are aware, and like you said, to listen to your symptoms, and that's the important piece. Don't be afraid. Step up and take care of yourself.
Thank you. If you would like to schedule a consultation with Dr. Delvadia in New Jersey or any of our other treating physicians across the country, you can visit sonatatreatment.com, where you can find our physician locator and be connected to their office through our nurse advocate to schedule a consultation. Again, sonatatreatment.com is where you could go and find our physician locator. Thank you very much for your time, Dr. Delvadia. We really appreciate you. And if you all would like to watch again, we'll be back on January 28th at 3 p.m. Pacific, 6 p.m. Eastern. And any information or questions that you need, please reach out and we can connect you with Dr. Delvadia if needed through our nurse advocate, Teresa. So thank you very much, Doctor.
Yeah. Thank you, Tara, and look forward to having more conversations in the future.
Thank you. Same.